Good afternoon, everybody. While you guys get your food, I'm going to get it started here. I'm Jürgen Unutzer. I'm the department chair, and I'm here to welcome our Grand Round speaker. Before I do that, I want to do one other thing, really brief. For those of you who get department email, you got an email yesterday about a new mentorship award that we're establishing in the department to honor Wayne Caton. It's been just about exactly 1 year. It's actually this week, a year ago, that Wayne passed away. And one of the things that we're doing to honor him is to develop a mentorship award in the department for a senior mentor. And those of you, like I said, who get department email, you've all got a little bit more information about that. Lydia Schwastiak is helping us select a good person for our first recipient. And if you would like to be nominated, if you would like to nominate someone, I'd like to invite you to do that. All right. So now I'm going to turn to introducing our Grand Round speaker for today, Dr. Mark Bauer. Mark is a professor of psychiatry at Harvard Medical School. He works there in the VA, and he leads a very interesting part of the organization called the Center for Healthcare Organization and Implementation Research. This is the kind of thing that didn't exist 10 years ago. He does some fascinating work in not only doing research on what better treatments look like, but once we have better treatments, how do we get them into organization? How do we do the kind of practice and organizational change that we need to do to really implement effective new programs. His work has covered a really wide range of recovery-oriented models for individuals with mental health conditions. He led some really fascinating work on improving care for patients with bipolar disorder. He has developed an approach to that called the Life Goals Collaborative Care Model. He's got a couple books out about that. And it's also a model that's now registered in the SAMHSA National Registry of Evidence-Based Practices. I don't think you're going to talk much about life goals today, right? Not too much, maybe a little. Along the way, he has sort of realized, like a number of us, once we have something that really works well, just publishing it in a medical journal doesn't change the world. People don't just change what they're doing. You have to do a few other things to really help implement and disseminate evidence-based practices, and he's become one of the national experts in this area, and he does that work in the VA. And I think that he's going to give us a fabulous introduction to this whole field of implementation science. That's something we all need to learn more about. I think the federal government would like us to spend less time doing research and more time translating our research into practice change. I think that the work of implementation science fits right there. And the other thing I will say is we have a special guest today, Karen Moe, who is one of our faculty members and whose day job is really to help run the UW IRB. Got wind of this presentation and said, I should probably come to this because we're getting a whole bunch of proposals in this area. And actually, for us, this is a difficult one to sort out. So I think hopefully we'll have a little time at the end of your presentation to have a little dialogue. So with that, I want to welcome you. In addition to being just a very established researcher, Mark is a wonderful person. He's a good friend of several of us. We've worked together over the years on a number of really fun projects, and I can guarantee you're going to enjoy hearing from Mark. Welcome.
Thanks, Jürgen. And it is indeed always a pleasure to come out to Seattle. I have collegial friends, and rarely do I come to a place with so many smart, nice people in the same place in academics. That's really great. So I'm delighted to be here, and thank you for the invitation. So we're going to talk about really a primer on what's called implementation science, and Jürgen, your comment that it's probably not more than 10 years old, I think is right on, and I think of it along with molecular biology and molecular genetics as two of the most cutting edge areas of the new millennium in biomedical research. A lot less flashy and a lot less well funded than molecular genetics, but hey, we got to start somewhere. So we're going to do the following today: talk about why should I care first, why worry about implementation, what is implementation research. We'll talk a little bit about theories, frameworks, and models and their role, and I will approach this as a theoretic nihilist. I've got dragged kicking and screaming, later in career into paying attention to models, and they actually do help. We'll talk about methods of implementation research. I'll then spend some time on implementation trials and the different types of trials, because it's a field that began by really describing barriers and facilitations to care translation, and now is much more in a later stage of really trying to get in and manipulate systems so that you can enhance the uptake of evidence-based care models. And we'll go through an example, real-world example, and then we'll come back and summarize. So why worry about implementation research? Well, when I got brought up in this area, there was sort of the classic academic model, which was you start with preclinical research, and you do efficacy studies under highly controlled conditions, and then naturally, public health will be improved. If it gets published in JAMA or JAMA Psychiatry or American Journal of Psychiatry, naturally people will pick it up and then run back to their clinics and start doing whatever you said. And as we all know, that doesn't happen. So this is why, to complicate things further, you've probably heard say about the 17-year lag that it takes from a evidence-based treatment to get established to its implementation in general clinical practice. And that's actually the good news, because the majority of evidence-based practices never really make it into practice. And this is not a new problem. This is not something because we're generating so much new research evidence. Let's look back a little while, back into the 1600s. And back in the 1600s, the first experimental trials showed that citrus juice cured scurvy. Took a little while to do the first randomized control trial to confirm that observation. Took a few more years for the Royal Navy to say, okay, let's make lime juice part of your daily ration, and even longer for the merchant marines to adopt it. So period of unnecessary scurvy deaths, about 264 years. So it's not new. But obviously we fixed it by now. How long does it take to get things into practice? And this is looking around the, kind of around the millennium. Proper dosing for antipsychotics, about 15 years to get them into guidelines. 15 independent RCTs of cognitive behavioral therapy for depression in the early 90s before things really began to move. When you get things into practice, they're not uniformly taken up. About 33% of heart failure patients get decent ACE inhibitor treatment. Hand washing among hospital staff, scary to all of us, about 50%. And mental health and substance use guideline concordant care in about 27% of studies and patients. So really, looking back around that time, and we can say looking forward, not so much differently, really, we don't have a superhighway, wide bandwidth movement of evidence-based practices into real practice. So the next iteration of trying to address this, and this developed around the millennium, was the introduction of what they call effectiveness trials. And your department here has been really a leader in doing a whole series of mental health effectiveness trials, saying that, well, you can't do these highly rarefied, very specialized studies and expect them to get moved into public health impact. So we will do more real-world studies, and we'll call those effectiveness studies. And the NIH has talked about the two types of transitional research, from bench to bedside and bedside or clinic to community, as being T1 and T2. So the difference between these studies, and we'll come back to this at the end, is working on different places along the pipeline. Efficacy trials are done under highly controlled conditions, whereas effectiveness trials seek to replicate conditions that you're going to run into in practice. Efficacy trials use primarily highly trained researchers or individuals that are under tight researcher control, whereas effectiveness trials use real-world trainers and real-world training conditions and fidelity monitoring. The patients that are treated in efficacy trials are usually highly selected to be simple and be well-behaved, while effectiveness trials take a broader and more generalizable sample, which has a lot more complexity to it. The focus of efficacy trials is to establish cause and effect. That is to say, to maximize the treatment impact if there is going to be a treatment there. Whereas for effectiveness trials, external validity and generalizability are more important. So this is sort of a needed added dimension to our trying to move things into public health impact. There are a number of names for this that you've heard. These are sort of overlapping Venn diagram terms, but they also, effectiveness trials are also often called practical clinical trials, pragmatic clinical trials, comparative effectiveness clinical trials, or large simple clinical trials. So the devotees of each of these will say, well, they're not all the same, but there's a lot of overlap. And the general idea is to do real-world trials under real-world conditions to try to move closer to public health impact. Well, still not enough. And this has been led to the development of implementation research, which we might consider T3. And that is the question of how to take interventions that have been proven effective and move them into public health impact. So the question is, can we move up this curve? This is the classic diffusion curve that Rogers outlined, which is an illustration of over time moving from left to right. You'll have more and more adopters, and it's not a linear rate of adoption, but they're the first people are the innovators who come first, and then gradually the early adopters, then the majority, then the late majority, and then finally the laggards. And the idea is that, and this is probably close to true for some treatments, that you get up to 100% of your potential target population using the intervention. For instance, serotonin reuptake inhibitors for depression or for most anxiety disorders. Probably, if you're treating those folks and you are a prescriber, chances are, we're pretty much 100% of us are using those kind of treatments. And this is an interesting little recasting of this distribution curve, because this frequency distribution curve, the adoption curve, which is quite famous, is really nothing but a frequency recalculation of a normal distribution of adoptiveness. So the idea is, can we move people more to the left, more to the early adopters side, and can we get up this curve farther and faster through implementation science? So there are challenges, and this is my favorite philosopher, Bill Waterston, featuring Calvin. He says, throwing these snowballs would give me immediate and certain pleasure. On the other hand, refraining from throwing these snowballs in hope of being rewarded at Christmas is delayed and uncertain pleasure. As usual, goodness hardly puts up a fight. And to translate that into implementation terms, using my old strategy will be productive right now, while trying this new strategy might be productive at some point in the future. Nah. So moving people into new behaviors is a difficult task. So what do we do? What is this field of implementation research that has grown up to focus on that movement, moving up that bell shape, up that frequency curve? Well, there are two types of implementation research studies: observational studies and controlled trials. And the observational studies tend to look at real-world conditions. They don't deal much with highly controlled academic medical center treatment situations, but look in the real world and do observations, and we'll talk about what kinds of tools are used, and or use implementation controlled trials where you test not the intervention, but ways of getting the intervention into practice. A good definition of implementation science comes from the founding editors of the journal Implementation Science. And they say it's the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practice into routine clinical practice, and hence to improve the quality and effectiveness of health services. So we're looking to improve the public health impact of evidence-based practices and move them into routine practice. And that will be the frame, and it's a different frame than we're used to thinking of in standard biomedical research, and that'll be the frame of what we're going to talk about moving forward. So let's define a couple of terms. I'll present a dyadic difference here: clinical intervention and implementation strategy, and it will be helpful to keep these separated in your mind, even though they tend to, in some ways, run together in the real world. So clinical intervention is an initiative, a manipulation, a change to be introduced into a healthcare venue. SRIs for depression or anxiety, cognitive behavioral therapy, aspirin after myocardial infarction, hypertension, weight reduction treatments, etc. On the other hand, an implementation strategy is a set or bundle or package of interventions to enhance the uptake of that intervention. So these things work to get these things into practice. So we'll think on two separate tracks. What's the evidence-based practice? And what's the strategy that you use to get it into wider usage? That is, so the control trials that are clinical trials will test the intervention to establish the evidence base, and then the implementation trials will test a method of implementing to try to get the clinical intervention into general practice. So this is where theories and frameworks and models come in. And as I was working on more on the left side of the pipeline, on the efficacy studies and even the effectiveness studies, I didn't think I needed much to do with models and theories. But when you get into implementation science, they can really be an important guide to your structuring trials and your observations. So there's, again, there are people that will take a little different tack on this, but I think the most generally accepted definitions of theories, models, and frameworks are that they're somewhat different. Theories describe meaningful relationships between components, like Bandura's social cognitive theory. Models are specific instances of the theory applied to real-world situation. And frameworks are really a checklist of what matters. And here's an example of a model that comes from Laura Damschroeder in the VA. It's a model for looking at and understanding how or whether weight management interventions are implemented in medical centers. And it runs like this. You need to have leadership engagement that drives two things: available resources and also sets goals and feedback. This makes implementing weight management interventions a relatively higher priority for clinic managers and for clinicians. They then do the intervention more intensively or more frequently, and it leads to better program outcomes. And the model includes leadership engagement and available resources, et cetera. It doesn't include things like parking spaces or necessarily telehealth technology or a whole bunch of the other things that could be moving parts in a very complex care system. So it's to help focus attention and AMR measurement and intervention tools. So it really is a matter, as I say here, of separating signal from noise, because there are always lots of moving parts in healthcare. And the foci can be on barriers to adoption or facilitators of adoption of the practice. And it typically models and theories address multiple levels: at the patient, the provider, the system, and even the external context. Much of what you who are individual clinicians working in the department have your behavior shaped by are things that are far, far external to you in terms of reimbursement strategies and medical center policies and things like that. So there's what happens at the front line is often determined on multiple levels. And types of models are really assessment or descriptive models, or models that take you into intervention and say this is where you should be putting your time and your effort to change practice. So let's talk about what some of the methods are, and we'll have models and theories as our backdrop. We'll talk about implementation interventions, implementation measures, and then the types of evaluation that are part of implementation studies. So strategies can target any one of a number of levels of care: the patient, the provider, the clinic, for instance, the healthcare system. Some of the common ones are education and training, use of the electronic health record, such as in clinical reminders or templates to make it easier to gather particular data, audit and feedback of provider behavior, incentives, pay for performance, toolkits, which are how-to guides, technical assistance by external content experts, or facilitation, which is a matter of getting brokers together to help different components of the medical center work together to more effectively bridge gaps and come together to work in ways that they hadn't worked as you change work roles. And typically, an implementation strategy will include a multiple of these things. It's very rarely now just one thing that just audit feedback. The days of audit feedback in your way to system change, I think, are behind us, because it doesn't. So some of you who are involved in quality improvement work are saying, well, this sounds similar to quality improvement, and in some ways it is. There are some differences between implementation science and quality improvement. Quality improvement usually begins with a particular problem, like the colonoscopes are not getting sterilized, or people aren't getting antidepressant treatment in sufficient doses, or the CBT is not getting done as completely as we'd like. Usually begins in a specific clinic, or it's typically hospital-based in some way rather than from outside. And it doesn't necessarily aim at generalizable knowledge. Quality improvement wants to typically fix a problem that's an everyday and important health system problem. Dissemination is usually focused on the spread of information, not changing systems, but providing information. And the educational strategies predominate. But there is a lot of overlap. In the implementation science aspects of this that would be similar would be some of the tools that are used. But typically, implementation science starts with an evidence-based practice and tries to move it further down that pipeline that I showed, rather than solve a particular problem. So the outcomes that implementation trials and observational studies look at focus on the uptake of evidence-based practices, and it's what many of us with our clinical trial hats on would think of as process measures. So we're not worried so much in implementation science about whether lithium improves bipolar symptoms, but we're worried and focusing more about whether you're getting lithium delivered in appropriate doses, whether you're getting lithium levels at the appropriate time, whether you're getting people persisting on lithium. So it's looking at process issues. It wouldn't be so much whether CBT is effective for depression, but whether you're actually able to deliver CBT effectively. But we'll come back to talk about how that's only part of the story in a little bit. But for classic implementation studies, it's really process evaluation is what is the focus. The measures are, again, a little bit different than you'd see in a typical clinical trial or observational study. They're typically mixed, using both quantitative and qualitative measures, and typically multi-level, looking at patient, provider, clinic, facility, organization, community, policy. And as I said, there's lots of moving parts here. So the models and theories that you would choose would be ones that would help you determine which of these multiple levels you wanted to pay attention to and which you could let go. And sorry to people out there in cyberland. So this is the cyber microphone. Okay. So the quantitative measures focus on structures, processes, behaviors, attitudes, and they come from things like administrative data. And I love talking with clinicians and with trainees who have really not gotten over the fact that you can actually determine a lot of healthcare impact by not talking with patients, but by looking at administratively collected data, such as utilization data, quality or cost data, using the electronic health record to access clinical information. Natural language processing is something that's coming and developing. I'm sure there's a lot of people here that are quite interested in that. Surveys and interviews of providers, patients, administrators. So again, very different than doing Hamilton Depression Rating Scales on, or Beck Depression inventories on people that you're in treatment for depression with. Qualitative measures are things that we also tend not to typically pay a lot of attention to in standard clinical research. Focus of these is to really develop a better understanding on a micro level of the data, the quantitative data that you've collected. They tend to be one of two types of data: hypothesis-driven or hypothesis-free. For instance, you could talk with individual providers or patients with a hypothesis that they will not get lithium levels because they forget to not take their medication in the mornings, or that they don't do their homework for CBT, and that's a reason that leads to despondency and dropout, or whatever it happens to be. Or you can do hypothesis-free explorations with qualitative data, looking at questions that are bigger, like, what are the barriers to facilitation of the use of CBT or the use of lithium or whatever it happens to be. Just seeing what comes up and codifying it in a structured and reasonably valid manner. The sources here, typically you're talking about interviews that are semi-structured, 30 minutes, 45 minutes, and they're with providers, patients, or administrators. And yes, you might imagine, talking with administrators is often a very important part of understanding why practices do or don't get put into general usage. And they tend to be relatively small samples. We have a study going on now that's going to be looking at between 600 and 700 patients and 72 providers. And that's not, and even that is somewhat large as a qualitative study goes. And there's something that, what I call a unique twist in looking at implementation, which is what we call formative evaluation. Now, the kind of the gold standard in doing a clinical trial and doing it well is you start at time zero and you lock down all of your practices, and you try to keep them invariant until the end of the trial. Well, in implementation work, they take a little bit more interest in what actually goes on during the trials to try to identify what are the influences on the process of implementation, and can be done using either the qualitative approach or quantitative or both. And the data are used to enhance the process of implementation during the study. So you're actually actively changing the intervention during the course of the study, or you're changing your implementation strategy depending on what kind of information you're picking up. And at first blush, this sounds like anathema to the classic clinical trialist, but when you think about it, there's no clinical trial that doesn't run without some of this, what we call fidelity monitoring, or mid-course corrections, and people doing their rating scales correctly, and treating physicians or providers, dosing lithium appropriately, or doing the CBT according to the manual, et cetera. So the difference between implementation and intervention trials and clinical trials in this sort of a setting, this aspect, is that they pay a lot more attention to these mid-course corrections as part of implementation, because the goal is to come out of it at the end of the study with the best possible implementation strategy that you have. So we'll talk about implementation trials. There are a number of types of trials. Randomized, controlled, and quasi-experimental. There are ABA or on-off-on designs where you implement, then you stop, and then you implement again. Parallel group designs are probably the most common. Something called stepped wedge designs are a variant of randomized controlled trials. That's one in which everyone gets the implementation support, but you randomize the time at which they get to start, so that at time 0, time 1, time 2, you have at each time you have a group that's getting the support and a group that's not getting the support, and you can do comparisons that way. And that's useful. That's useful for ethical or policy reasons when everybody needs to get the implementation support. Then for large studies, there's something called adaptive randomization, where you randomize studies to get support or not support, randomize sites to get support or not support. Then those that got support, some of them will reach criteria for success and some will not. And those that don't get randomized to either continue to do what they were doing or to get a change. And it's a way of processing a lot of formative evaluation data in a somewhat structured way. Quasi-experimental designs include historical controls with matching, interrupted time series, and also experiments of nature. And by nature, we include not just like acts of the natural world, so much like Hurricane Katrina, as much as administrative changes and policy changes, where you can see dramatic shifts in behavior and make sense of the impact of the policy by looking just in serial, in series over time. So that's a really, really quick walk through the basics, the geography of implementation science. So there's the The idea is to not look at the impact clinically so much as look at the use of a treatment. You use qualitative and quantitative data to understand the barriers and facilitators to implementation. You look across multiple levels, and in some ways, most of the work is done with providers, clinics, and administrators, and relatively less is done with patients directly. So we'll put some meat on the bones here by walking you through a real-world example of a controlled trial in the implementation area. And this is a study that is led by, or was led by Amy Kilborn at the University of Michigan, where we took 7 community-based clinics across Colorado and Michigan who had a lot of folks with bipolar disorder that they were treating. And as we said earlier, the focus is not what's the impact of the intervention, but all the sites get the intervention. So we can't conclude much about the worth of the intervention, and it's the Bipolar Life Goals Collaborative Care Model, which is highly evidence-based, and it's in practice guidelines, and I'll show you the schematic to give you an idea of what it is. But all sites get this intervention for bipolar disorder, but the randomization comes that the sites are randomized to one of 2 implementation strategies, either what we call blended facilitation or standard training. So everybody would came in and got training about how to do life goals collaborative care. Half of the sites also got engaged with facilitators, and I'll describe what they did. I think you'll get some of the flavor of what implementation work is like. But first, this is the care model. There are 3 components: providers, patients, and the healthcare system. We provided provider decision support through simplified practice guidelines, patient self-management skill enhancement by using our manualized life goals group self-management program, and then a mental health care manager to both to do the patient self-management skill enhancement, and then also to provide access continuity, increased measurement-based care, so as to link these 2 otherwise unconnected circles of the Venn diagram. So provider decision support, patient self-management support, and access continuity enhancement with the care manager. The implementation strategy we used is this blended internal-external facilitation, where we identified and had the clinic pony up some time for an internal facilitator out of their sort of wallet. And this, excuse me, the facilitator assists the clinic in implementing after training, so does troubleshooting, resource gathering, dealing with leadership issues, meets with clinical leadership on a regular basis, adapts the program so that it works with the workflow. It's really hard to come into a place and say, if you've got a group treatment, and say, okay, we're going to do group treatment here, but there's no group rooms. So what do this is like not rocket science. It's not nearly as elegant as molecular genetics, but if you want to get the treatment into the real world and it's a group treatment, you have to figure out how to do group rooms. And then also selling and engaging leadership around how this fits in with long-term plans and their priorities, so that you can you can keep them engaged and keep them supporting it. And then they work in tandem with an external facilitator who's a research team member who is an expert in working with systems and does a lot of technology transfer, knowledge transfer to the internal facilitator to help them work with the multiple organizational levels, mentors them on facilitation skills, helps them with problem solving across all the levels of the organization, provides additional guidance for the clinicians if they need it in how the care model is working, helps them to set goals that are relevant so that you can keep leadership on board, and also summarize and publicizing progress so that people get positive feedback about what they're doing, and also can identify areas where they need to do more work. So, and then overall planning the business case. So the outcomes look like this. So self-management sessions completed, all 4 of them. Blended facilitation, 64%. Standard training, 22%. Total number of self-management and care management contacts, about 8 versus 5, and these were highly significant. Facilitation clinic patients, 7-fold more likely to achieve minimum treatment fidelity that we'd set out beforehand, and 22-fold more likely to achieve optimum treatment fidelity. So it appears that investing in internal and external support through facilitation can actually move a complex intervention, a multi-part intervention like collaborative care, into more general use, and particularly in these were federally qualified health plans or community mental health centers. So sort of frontline treatment venues, very different than academic medical centers. But under standard conditions, there's obviously room to improve. So that's implementation science, trying to move things that are evidence-based from clinical trials into general usage. And so we should just stop there. Well, there are more issues. So this is one of my favorite studies. It's of prostate cancer with an implementation. They didn't call it implementation science, but they did implementation facilitation to increase the rates of PSA screening. And you can see that the rates of screening over years were, from the get-go, were higher in those places where screening was achieved. But the impact on health outcomes was negligible. So even doing work that gets evidence-based treatments and strategies into practice does not necessarily guarantee health outcome improvements. And so we and a number of people have talked about hybrid designs, and I'll just mention these briefly, where we combine characteristics of effectiveness research and implementation research, and there are three types of hybrids. One is a traditional clinical effectiveness trial that has observational implementation components. So from the get-go, you dedicate some of your staff to collecting experiences, identifying barriers and facilitators to what made the effectiveness trial go better or worse, and what were the predictors of successful use. And that sets you up to go into the next stage of trial, which is hybrid type 3 trials, which are classic implementation trials like the one I just illustrated, where you look at your focuses on randomizing strategy to strategy, but then you're also collecting health outcomes data as well. And hybrid type 2s are simply a hybrid of hybrids where you jointly focus on both intervention outcomes and implementation outcomes equipotently or with equal attention. And those are used when there's health system impetus to change with something that's less than evidence-based, and they're saying, please help us get this into practice. And we're saying, yes, we'll help you get this into practice. Wouldn't you like to know whether it does any good at the same time? So hybrid designs try to address that issue of shortening the feedback loop from efficacy, effectiveness, implementation, lather, rinse, repeat, to change an intervention to go back and do another effectiveness trial. But we're trying to do both things at the same time, both effectiveness work and implementation work to speed the move through the pipeline. So that's a quick walkthrough. I'll close with just a reprise of a hypothetical study to illustrate some of the concepts and the differences. And and I apologize for the acronyms here, but let's make up a study of 6 sessions of motivational intervention for substance use disorders in the homeless population. So MI has been used for substance use disorders like forever, not so much so in the homeless population. So you could say, well, let's do an efficacy trial, and the hypothesis would be that motivational interviewing would beat your control. Population, you'd want to use a fairly clean population of substance users who were homeless, so you'd exclude those with psychosis or bipolar disorder, anxiety, and other things. Your intervention clinicians would be highly degreed and highly trained. They'd be trained to criteria, and they'd be watched for fidelity, and probably through audio tapes. You'd measure a lot of outcomes just because you didn't want to miss anything and you wanted to look for secondary advantages. The overall context is to, as I say, make it so at all costs. Make sure that you get good MI delivered in 6 sessions to people with substance use disorders who are not terribly complicated. And the research support is definitely there. There's what I call crypto case management. If somebody doesn't show up for their rating scale or their session, you go out and find them, you bring them in. All that's well and good. And it's all in the service of high internal validity. So can you make this treatment work in this population? By contrast, an effectiveness study would loosen the reins and change things a little bit. MI beats control is still your hypothesis. Your population would be a more typical substance-using homeless population, which would include some of the comorbidities that were otherwise excluded. Your intervention clinicians would be more of the real-world folks that you would see in a homeless program. Addiction counselors, for instance, hired as study staff. They'd be trained to criterion, and you do some light touch monitoring that would be more typical for the community program in which they were working in. You wouldn't, in a typical community program, you might get supervision, but you wouldn't get audio taped. The outcome measures, because you're working with a more complicated, less research tolerant population, would be simpler. Usually, if you have the classic efficacy study has weekly 1-hour research assessments, the typical effectiveness study might be telephone interviews, take 20 minutes or 30 minutes every month or something like that. The context or the overview of what you're trying to do is to work within typical conditions. There is research support because it's a controlled trial, but it's usually firewalled in some way so you avoid the crypto case management, and it's all in the service of making sure that you have generalizable results in the real world when you do. So those are sort of the two on the left side of the pipeline to public health impact. And implementation trials are a little bit different. So the hypothesis, from the very beginning, the hypothesis is different. And the hypothesis is not MI will beat control in terms of treating substance abuse. It is we can teach MI and it'll be taken up. The unit of observation could be the patient, it could be the clinic, it could even be the provider. You typically work with addiction counselors who were typical for that community setting. They wouldn't be hired by research funds typically. The intervention, the approach to intervention fidelity would be not making sure people are on the straight and narrow, although you would do some of that, but it would be more identifying places where there are alternatives to implementing the intervention and try to improve it over the course of the study. The outcome measures would be adoption of MI primarily, with secondarily for a hybrid trial, you'd look at health outcomes. The context is very important to maintain the typical conditions. You don't want to be muddying the waters with exogenous research support except for the facilitation and training, and the research support is mainly used for those things. And as I say here, the plan is to mess with internal validity so that you have a different intervention, a better intervention by the end of the study than you did when you went in at the beginning. So, to summarize, implementation science continues the job of biomedical research. It's not just a matter of getting new knowledge, but getting it out there into practice. It takes evidence-based interventions and test strategies to move them into practice. Classic notions of validity are adjusted to end up the study with the best possible intervention going forward. And the interface is very close with operational and clinical partners. And it does a lot to break down the research practice divide. And that's a whole other area we could talk about, partner-based research. And I know there's a lot of work that you're doing here, and you're certainly at the forefront of working with health systems to get interventions into practice so that they stick. And the ultimate goal, again, is to improve the public health impact, to get things all the way through that pipeline. I'll make the slide set available. There's a series of resources here. Implementation Science is a well-established journal with a really pretty reasonable impact factor for those of you that count that stuff. The VA has been doing this implementation research since the very beginning of the Quality Enhancement Research Initiative program, has extensive resources. The NIH is catching up rapidly, and there's a couple of our recent papers there that might be helpful. So let me stop there. We've got, I guess, about 10 minutes for questions.
Yeah, I'll start with one. Can you go back about 2 or 3 slides to the 3 columns?
This was a fabulous presentation. Thank you. And we have in the department research that fits into every one of these three buckets. Mm-hmm. And the question I have for you is it always going to go from here to here to here? Or once we do a lot of this, how is this going to inform what we do here and here?
Yeah, that's a really good question. And I'm supposed to repeat the question for people who couldn't hear it. Okay. Despite what my wife will tell me, I'm pretty good at following directions. So Jürgen's saying that, and this really kudos to the department for having a much broader spectrum of activity across these columns than virtually any other department in the country. But is it always a feed forward from efficacy through implementation, or are there loops here, to paraphrase a little bit what you said? And yes, there absolutely are loops. And our work with hybrid designs has been one of the ways we want to shorten those loops. But I guess CBT is my stalking horse for the day. Let's say you do an implementation trial of CBT in folks with bipolar disorder, and you find that they just can't do the homework, and you've done that despite the best implementation support that you can give them, and their lives are just too chaotic, and the dog eats it, and they just don't do the homework. So one of the messages, oops, I drew on my slides, but I know Josh can fix this. Don't worry about it. Well, what the arrow was going to do was to draw a loop back there. So it tells us that probably there's a need in the real world for CBT for bipolar disorder that doesn't include doing homework. So would we go all the way back to an efficacy trial? Well, maybe we would. Maybe we jump into an effectiveness trial. Maybe we jump into an implementation trial. Or maybe if we're doing a hybrid design, we would find that they didn't do the homework, but it didn't matter because their outcomes were the same, and then we forget about CBT homework and go on from there. So yes, the pipeline, the pipeline I showed is sort of classic VA query pipeline, which has been sort of retired. I think it's a good teaching tool, but there are many more loops than that simple pipeline would have you it leads you to expect. So.
Right, and if you don't ever say to the person making the nth flavor of CBT that people don't do homework, they're going to continue to make new trials of stuff that involves homework. So I think that's incredibly important to feedback.
Yeah, and I would also add that there are walls and stovepipes within these columns in our field that we really need to be aware of, because we don't necessarily talk so well up and down the pipeline. We don't, because some of those conversations unfortunately end up with, well, you weren't doing CBT. I can remember going back to some of the NIH conferences where when effectiveness research was just getting going, and people really not even being able to talk together about common measures or common strategies, because everything, the further down the right side of the pipeline you got, the sloppier and less scientific things got. By the same token, people on the intervention side, the implementation side, will tend to have the fantasy that they'll have a black box that they're trying to move into practice, and not be aware enough of how dependent they are on clinical intervention developers to work with them to change the interventions as things are needing to be changed. So, yes?
Can you think of any implementations that were easy and went very quickly? Or did you mention any?
Can I think of any implementations that went easily or quickly?
Right.
I can. The one that I've lived through, and you may have lived through too, is well, I'm thinking about the introduction of serotonin reuptake inhibitors for depression and anxiety. It took the world by storm. And I think, what we've heard is that they're better and better tolerated for depression than tricyclics. And if you really look at those data, it's not so cut and dried as it is. And I think the implementation lessons are there, that if I put somebody on Prozac and then I will tell them, take 20 milligrams, come back and see me in 6 weeks, then I'll go on to my next patient. If I tell somebody with dizipramine, I'm going to put you on dizipramine, I'm going to give you a complicated titration schedule that I have to write out. There's multiple steps to it. Oh, and by the way, I have to ask you about your vision, your urine, your bowel movements, and then I have to send you down for an EKG, and you're going to go down and get the EKG, which may be across town, but even if it's downstairs, you're going to bring it back to me, and I'm not going to know what it says. You're going to knock on the door, and I'm with the next patient. I think it's really why they took the world by storm. Besides all the pharmaceutical marketing, they're just so much easier to use than tricyclics, and I think there's lots of lessons there. In fact, Rogers has done some really wonderful sort of unpacking of interventions and what makes them adaptable or not, and things like complexity, how difficult it is to do, trialability. Can I back off of it, or do I have to buy a big machine to do it?
That's exactly what I was looking for, was the complexity, because evidently if you can phrase your message in fourth grade language, it'll catch on a lot faster.
Yeah, so complexity is really a showstopper.
SSRIs instead of TCAs, and then also, hey, I drank the extract from somebody's GI tract that had ulcers. I gave myself ulcers. I took an antibiotic. I cured myself. I won a Nobel Prize. Why don't you be a winner like me too, instead of a loser? And that caught on, 5 years? Antibiotics for peptic ulcer disease. So I think the part that I was looking for was if the complexity of the message is simple enough, that it will catch on very quickly. So
complexity is a real. If there's no other stops, having something less complex than what you're doing is always a help. Yeah. Yes.
I think I would agree with part, but if you really think about some of the outcomes of implementation, I don't know that I would say that, because we still struggle to make sure that people get treated for depression, even though SSRIs are everywhere. So I think it addresses part of the implementation challenge, but there's a whole nother piece. And I think my question has to do with, are we at a point where we can think about the various strategies that would be in the implementation column to unbundle them? Or in another way, why would a facilitated engagement intervention work for one thing, but not work for something else? Because I think that's what I'm starting to see in the literature.
Yeah, I think that's really a good point. And the question is, if I'm getting it right, why? There's got to be a better way to go backwards to these slides. I don't want to give everybody epilepsy. Okay. So are we at a point where we can do a couple of things? One is pare back and unbundle strategies, and the other is can we mix and match? Can we match to the needs? Where we are is, I don't know where we'll be as a field in 10 years, but where we are now is realizing that individual strategies on this list don't work. And I think I was rereading the classic Michael von Korff, Ed Wagner article on the development of chronic care models. The reason they developed them was because individual components didn't work really well in changing behavior. So we're kind of at that stage. Now, 10 years from now, 15 years from now, will we say that, well, clinical reminders plus facilitation are really where it's at, and the rest we don't have to worry about, or in this situation, you can use an internal facilitator, and this you can use an external facilitator. We may get to that point. I think the smart money is on the more complex the problem, the more you're going to depend on facilitation, which has to do almost and sometimes with group therapy, with group dynamics, with understanding organizations. The simpler the problem, probably the less you can get away with. There are, if you talk to 5 facilitation using implementation scientists, they'll talk about various different flavors. And we have a working group of about 60 or 70 researchers in the VA that meet monthly to try to define what we mean by facilitation and develop fidelity measures for facilitation. So we're very much in formative developmental stages. But yes, it would be great to be able to match treatments. But in general, the more multi-level, the more complex, the more complicated the strategy is going to be, and it's almost always going to involve some sort of facilitation. Questions? Good. Well, thank you very much. It's been a pleasure as you always.